I have held people's hands while they died. I have held children in my arms while they died. Those take real difficult toll on you. Nursing is the most trusted profession.
How does that add up? I'm just trying to wonder, how can we, as consumers, support nurses more?
You, the patient, really are in charge of your care.
All right, welcome on into the Health Elevated podcast. I'm Dr. Fowers, joined by Dr. David Hedges and Dr. Gee. And, in healthcare, the person you probably interact with the most, in my opinion, is a nurse, right? You spend a little bit of time with a doctor, a little bit of time with a pharmacist, but I feel like a lot of our interactions with the healthcare system often goes through nurses. They are a vital part, frankly, doing a lot of the heavy lifting in the healthcare system. And our friend, Dr. Perry Gee here, is what is called a nurse scientist, which is a fascinating... Well, let me ask you, what even is a nurse scientist, Perry?
To be honest with you, I didn't know what it was when I was first asked to become a nurse scientist. But what a nurse scientist is a person who is promoting nursing research. And, well, let me back up one step and just say all nurses are trained as scientists. My title happens to be nurse scientist because my role is really to promote nursing research and the best use of evidence. And so I conduct research and I help teach research to our nurses. I try to get them involved. I'm really kind of a cheerleader for research, if you will.
I kind of presented this idea that, nurses probably are doing most of the heavy lifting when it comes to the actual healthcare part of the healthcare system in the United States. Is that accurate?
Nurses are at least in the hospital setting, nurses are there 24/7, 365 days a year. We probably spend more time with patients than any other discipline. If you come into the hospital and spend the night, there will be a nurse with you most of that time, a nurse assigned to you most of that time. And so you will always have a nurse with you. When a physician or a therapist or somebody else comes in, they spend less time at the patient bedside. I'm not saying that their work is any less valuable. It's just less time at the bedside. So we do a lot of heavy lifting, if you really think of it that way, especially since we're working all night and on weekends and on holidays. And I'm probably not the typical nurse you would expect to see. Although I have to say, in the state of Utah, we have the highest percentage of male nurses in the United States. We have 12% of our nurses in Utah are male nurses. That's more than the national average, which is somewhere around 10% of nurses.
If you could estimate the impact of a good nurse versus a bad nurse. Okay, so suppose I get sick, I go into the hospital, I'm interacting with the hospital system for a variety of treatments or whatever, and I go through that, and maybe we clone me, and I have one of me's going through, and I have just an excellent nurse, a great bedside manner, lots of compassion, explains and listens to everything, that all of my concerns, answers my questions, is patient with me. And the other me goes through with a terrible nurse who's mad and sad to be there and has no compassion and has terrible bedside manner. Does that have an impact on my health? Am I going to end up the same either way just because by virtue of technology in the system? Or is there a real impact that, wow, the me who had the bad nurse actually might have ended off worse, even though we, in this theoretical situation, went through the same system? What's the impact of a good nurse versus a bad nurse, do you think?
We are starting to measure that impact really all over the United States. And I think I'm biased, but I'm going to say I think there is an impact. But hopefully, by the way, you're not going to run into that bad nurse very often. Every nurse and every physician and every human has a bad day. And that even rubs off in the patient care setting. And I hope that we have enough balances in place to take care of that we're watching out for each other. If there's what they would call a bad nurse on a unit, I certainly hope that the charge nurse or other fellow nurses, or maybe the nurse's aide or a therapist, notices that nurse having some trouble and intervenes, because we really shouldn't have anybody who's having a bad day, who's taking it out on patients or families or anybody like that. Now, with that said, does that happen sometimes in healthcare? Sure, it does. And I think it could impact patient care, because if a nurse is not listening, is not paying attention, there may be a subtle cue that they miss in your assessment. There may be an error that somebody could make in a calculation. And so we don't want to have any of that. So we want everybody on their best behavior. And we do hear stories, of nurses and physicians and others around the country who are struggling with their behavior on duty. But we're really making a conscious effort today to try to get ahead of that, to stop that, to keep track of one another. In fact, we have a campaign going on at my company right now where we're checking on one another. That's one of the things that we're doing. There's so many of us. We don't have enough therapists or others to check on each other. So to check on all of us. So we're checking on each other.
So a couple of things come to mind because, for this podcast, we're hopefully focusing on the people, the everyday people who may or may not be nurses. I mean, it can include people who are nurses too, and how they can best, improve their health and live the healthiest life possible and whatnot. And I'm thinking about the role of the patient in this situation. So
Yeah.
how like if you do come across a bad nurse, or you're having like some kind of problem there, right? Somehow this nurse slipped through all the cracks of these systems that you talked about and put into place that hopefully makes this a very rare occurrence. But how much ownership and power does a patient have if they're in a situation where they feel like they're not being listened to, for example?
That is such a powerful question, really super important, and something that I hope everybody will hear. And that is, you, the patient, really are in charge of your care. And it's easy for patients to enter the hospital and think, you know what, I've got to do what I'm told here. I'm concerned that if I don't behave the way people want, that I won't get the care that I need. There are fears that patients have naturally, that they're at the mercy of the healthcare system, but they're not. The patient is the center of the healthcare system. So if you as a patient ever have any fear that a nurse or any other caregiver is not appropriate or really not a good fit for you, I would recommend asking to speak with the charge nurse or the nurse manager or somebody else on that department to make sure that you are heard and that your concerns are heard. Maybe there just isn't a good match. Maybe this nurse and I, we just don't see eye to eye. And that happens sometimes. It's happened to me in my career. I've had patients in my career that have said, you know what, I'd really rather not have a male nurse if that's possible. And that's okay. It doesn't happen very often. It probably happened once a year, maybe. And I was not offended or anything like that. We just made a change to an assignment if we could. The other thing is, I would encourage you to work with your nurse as just like you would with your physician, as a partner. See if they would be able to take 5 minutes to sit with you and talk about your concerns and say, hey, how can I partner with you? What are the things that you want me to tell you that will help me get better care, help me get everything that I need, help me learn what I need? That might be hard for the patient to do. And so hopefully the family can do that as well. By the way, the family is really, or friends or people that are there with you, are really just as an important part of the care process as anybody else. And then the other thing is that we have other healthcare providers that can help. Some of our hospitals have medical chaplains where you could talk to the chaplain about the nursing care that you're receiving, or about working with a social worker, or how things went with the physical therapist. You could talk with them very openly. They're a safe person to talk to, just like the nurse should be. They should be a person that you could share your most intimate secrets. You know what? It really hurts when this happens to me. or and by the way, sometimes patients have to share really intimate details with us, and that's okay. Remember, well, I don't know if you know this, but for the last 23 years in a row, nursing is the most trusted profession of all professions, regardless. That's including law enforcement and other professions. Nursing, year after year after year, is the most trusted profession. I think as a patient, I trust the nurses. I use the healthcare system now, and I really trust the nurses. I can tell them what I need. I know they're going to be confidential, and I know they're going to be respectful of what I need.
So I have a question that kind of prompts with me. Um, so nurses at the end of the day, they're people. They've got their own, fears, pressures, all of that. They're people just like we are. I think a
Mhm.
lot of times we don't see professionals as people. We kind of just see them as, in this category of professionals, and it's hard to interact with them in that way. But what kind of a burden does being a trusted entity, what does that put on nurses? I also know nurses have a pretty high burnout rate, and a lot of times the nurses really struggle to stay engaged, and it takes a pretty big toll on nurses' mental health, etc. How does that add up? I'm just trying to wonder, how can we as consumers support nurses more to reduce that burnout to improve the overall quality of care? Because it seems to
Pay
me,
them more.
well, well, the always the solution, right? But outside of that, perhaps.
That is another great question, and it's something that's really important. I have to tell you, so I've been studying burnout for decades now, both scientifically and at the unit level. And I can tell you that we're able to talk about burnout now. We weren't able to talk about that in the past. In fact, we were asked to kind of keep that to ourselves. Patients and families and others don't want to hear about people who've got a pretty good job and a decent lifestyle. They don't really want to hear about our complaints about work. Burnout is real, but what I might say, David, is that there's more to it than that. So burnout is a workplace condition.
Okay.
And it's not a mental health condition at all. It's an actual workplace condition. If we weren't working, we wouldn't be burned out. So it's difficult things at work, weird processes, policies that make things difficult, weird technology, all those different things that we do to workers to create an environment that's more difficult than it needs to be. That's really what burnout is. But the other things are the ones that really matter. So, for example, I think compassion fatigue, that is a scientific construct that's measured. We have several instruments that can measure compassion fatigue and even compassion satisfaction. And compassion fatigue is nurses taking care of very ill patients day after day after day without any compassion satisfaction to counteract that,
Huh.
get tired and fatigued, and sometimes people call that burnout. And normally the way we counteract that compassion fatigue is just by our interactions with patients, and you know that as a human being. When you pour compassion out to another human being, it usually makes you feel good as well. I was there for that person. I held their hand during a difficult time. I listened to them when they were in pain. That is how you receive your compassion satisfaction. But if you give out compassion all day, every day, and you don't feel that satisfaction, then you can have compassion fatigue. And some people will call that burnout. The other thing that they call burnout at times is moral distress. And we have a lot of moral distress in healthcare. It's tough. That's one of the things that nurses deal with, and doctors, but nurses deal with every single day usually, is some sort of a moral decision. It might be, are we providing too much care for this patient, way more care than this patient wants? Are we not providing enough care for this patient? A real good example of that, of course, was during the COVID pandemic when we weren't able to allow family members to visit patients. That created a tremendous amount of moral distress for nurses. Over time, that moral distress builds up and becomes moral injury. And moral injury is very similar to PTSD. That's what soldiers come home with, is moral injury. So, and if you measure before the pandemic, about 20% of nurses across the nation had some degree of moral distress. or some degree of PTSD. So that is another one of those things. One other thing that nurses face every single day that impacts the way they feel mentally is secondary trauma. So that is experiencing the suffering of others. We do that all day and every day. It's really hard. It is really hard to deal with a patient who's in severe pain, and you take on some of that suffering, right? Or I can tell you in my career multiple times, I have held people's hands while they died. I have held children in my arms while they died. Those take a real difficult toll on you. The children for me were the worst. First time I experienced that was terrible. And I still think about those deaths probably every day. And some of those occurred over 30 years ago. Those
Wow.
kinds of things all sometimes get lumped together under the term of burnout. But I
Huh.
think it's important for us to identify where the problems are coming from so that we can deal with them individually.
Holy cow.
Fascinating. I wasn't aware of those breakdowns.
I was saying pay them more, but like you hear that and you're like, wow, they're severely underpaid because you're right. Like when it comes to the healthcare system, the nurses are that front line of defense, if you will, because all that stuff you're talking about has a real burden, and they have to kind of absorb that as much as they can and still be a great compassionate person to the next to the next room, to the next patient and whatnot. Man, I know that's kind of one of the areas that you're studying is kind of like how to take care of our nurses, how to optimize them, and all of that nurse science, right? And just from an outsider's perspective, though, maybe I'm wrong about this, but it also seems like, at least in the United States, that nurse jobs are always available. Like, are places just severely understaffed? Because I kind of get that sense. I don't know if that's accurate, and I wonder, like, if there is some power in alleviating some of this distress and burnout and everything else that you talked about in just having more nurses across the board. Because not only does that, help kind of spread it out a little bit more, but I also think, if you're a nurse and you have a nurse friend, and maybe you can talk more about this, like, wouldn't that be just a great resource to have? You have a friend who's also experiencing the same kind of things that can talk about, like, man, I went through this terrible thing with this patient. I'm having a hard time with this. I know you go through things, like, you can understand what it's like to, like you said, like, hold someone's hand while they're dying and actually talk to the people who've been through that. So I don't know, like, do you think staffing could potentially solve some of these issues?
Well, I like the idea of talking about different forms of staffing because staffing has been a question. I've been in healthcare for 45 years. Staffing has been a question all 45 of those years, and it's still a question to this day. And I hear staffing questions all the time. When I go out there and talk to nurses, they'll frequently say, well, you're doing all these other things, Perry. That's great, but what about staffing? And, honestly, I have very little to do with that. But I can tell you that as a nursing industry, we've studied staffing very carefully. We've been following it for years and years and years. We've done a lot of research around that area. And I know, for example, for my company, because I actually see the staffing, we're actually staffed really very well here. It may not feel like it every single day to every single nurse, but I can tell you our staffing is as good as anybody in the nation, which is really, really good news. We've had different things in different states. So Massachusetts and California have tried mandated staffing ratios. And there's been some good and bad with that. One of the things that happens because healthcare is a industry, if they have to put a whole bunch of money in staffing in one area, then they're going to have to reduce staffing in another area. So when we were in California and they implemented staffing ratios and it was by law, it had to happen. You were fined if it didn't happen. What they did was they got rid of the unit secretaries and they got rid of the dietary aides that were passing out trays for patients. And they said, sorry, nurses, you guys are going to have to pick that duty up now because we have to pay for the extra nurses. So in the end, it wasn't very satisfying. It might be more satisfying to the patients, though. And we know that places that do not staff adequately do have higher degrees of mortality and higher degrees of problems with infection rates and other bad outcomes. And that's why staffing has been looked at very carefully. And staffing is different from state to state to state. Every state is slightly different in the way that they manage that. I happen to live in a state where we don't have a huge nursing shortage today, but some of our surrounding states do. And, right after the pandemic, we had some healthcare systems that had a 30% vacancy rate, which is really difficult. For what you were both talking about earlier about burnout and some of the other mental distress things that go on with nursing, we've had a turnover rate with young nurses, extremely high turnover rates all over the United States. And we're having lots of nurses leave the profession entirely before their second year, which
I
is
was just about to
really
ask,
sad.
what's
Yeah.
the average turnover rate, like a tenure, I guess, of a nurse?
Well, all of that is changing right before our eyes because the
Yeah.
boomers like me are starting to cycle out, right? So
Mhm.
right now we're the largest nursing workforce, the baby boomers, but we're
Really?
rapidly dropping off.
Hmm.
And you can actually see that whole shift in the spike as we all start retiring and dropping off.
So
And there's a
does
new
that mean
group.
we're like heading for a precipice, a massive nursing shortage?
Yeah, well, it's kind of like anything else. There's been lots of gloom and doom out there talking about these massive nursing shortages. We haven't seen one recently, but they keep saying it's coming. In fact, there's supposed to be one that's here right now, but it hasn't hit yet. They do say at 2030, we're probably going to be maybe 1 million nurses short nationwide. Keep in mind, there's only 4 million nurses in the nation to begin
Oh,
with.
wow.
So
That's
we're trying to replace now in the state of Utah where I live, we're replacing nurses as fast as they're retiring. So we're doing a good job with educating nurses. That's not true in every state, though.
so
Is nursing school too hard? Like, what do we need to do to get people to replace the baby boomers, as you say, that are
or
leaving?
maybe it's not a question of training more nurses. Maybe like if so many nurses quit after year one, if you could
Yeah,
if you could extend the tenure out to 3 years, then that
that'd
would
be huge.
significantly increase numbers right there.
We are really working on, number one, keeping those nurses that we have. That's really valuable. So that's one of the things that we're working on now. How can we retain those nurses in the first 2 years? And we're trying all kinds of different things, different training programs, well-being programs, trying to make them feel welcome, having coaches. We're trying to do things like that. So I think that's really important. And then we have to work smarter as well. And that's one of the things that our leaders are working on right now. How can we work smarter? So can we use AI to help us? Can we use ambient listening to help us with some things? Can we use AI to help us keep track of a patient that might be trying to crawl out of bed? And yes, we can. And we're trialing that kind of stuff here. Can we use a virtual nurse to help with admissions and discharges and transfers of patients that take so much time? When you admit a patient, sometimes you get these, well, we used to get packets, but you get giant computer screens full of documentation that needs to occur. It might take an hour to admit somebody. Well, now we can use a virtual nurse to do that. By the way, the virtual nurses that we're trying are nurses that work on that floor, but are sitting in a booth somewhere or sitting at home, virtually interacting with the patient through a TV screen, interacting back and forth, and just being like an extra pair of hands, but an extra pair of eyes really in the unit. So it's
Interesting.
those are kinds of things that we can do. We need to work smarter. We still, honestly, we still do a lot of stuff in nursing that we did when I became a nurse 40 years ago. We haven't changed our processes very much. So it's time for us to do that, to be more innovative.
So another kind of question that we were not supposed to talk about. So when Rylan mentioned earlier, just pay nurses more. How many nurses are leaving because the pay isn't competitive with other fields?
I hear that from time to time, but I don't know the actual numbers. In the
Yeah.
end, when we talk to nurses about the things that impact them, the things that makes them the maddest, they usually start out talking about salary and staffing. Those are the two things that we talk about. But when we have time to really sit and visit about these things, mostly it gets down to, I want to be able to spend time with my patient. I want to have that interaction, that compassion, satisfaction I was talking about a minute ago. I want that interaction. That's why I became a nurse, to help somebody. If I'm just running around, I'm not very satisfied. I don't know if I want to stay in this profession. But if I'm there helping people, then I might want to stay. It's interesting. I used to work in inner city San Francisco for a health system out there. In one of our emergency departments, we had the highest paid regular staff nurses in the United States in the emergency department there. They were making just double the money that nurses in other Western states are making. They were the most unhappy groups of nurses I've ever worked with. They did
Interesting.
not like their job. They didn't like they weren't friendly to their patients. They weren't friendly to each other. Having a meeting with them was almost like a battle. It was so interesting. And so they had other things, though, that they didn't like. They didn't like their 3-hour commute at the end of work, in
Okay.
San Francisco, going back to the East Bay or whatever it was. So there's all those different kinds of things that they were dealing with. They just had a different set of concerns.
Interesting. I know I've talked with nurses firsthand, and they always complain about salary and say that's the number one reason they're leaving. But I've never talked to them deeply enough to know if there's other things. I wonder if it's more of a trade-off. If you can't have the time to provide that compassion, you might as well get paid well. If that's kind of the attitude.
Right.
So,
Right.
I don't know. I also with commuting, I've heard that commuting is the number one factor that leads to job dissatisfaction across the board. Like the longer you commute, the more unhappy people are. So if you're commuting 3 hours one way,
Oh,
that's going to impact you.
That's a long way.
yeah, it would be terrible.
So we've talked a lot about nurses, and I think a lot of the things we've talked about apply to individuals who are receiving healthcare as well. Not to mention, we also talked about that from the consumer perspective. But now is our opportunity to hear from Dr. Gee, a 1 minute for 1%.
Great. Well, I can tell you in 1 minute, here's something that any of you can do. And you could do it right now, and it doesn't cost anything. And that is focus on compassion. And compassion is a skill that you can build. I didn't realize that until I studied the science of compassion. There's the compassion that you give to other people, that you might give to your neighbor or family or friend. There's the compassion that we receive from other people. We're less good at that. We typically say, oh, it's okay, I'm fine, when we may not be. But it's that compassion you have for yourself. Self-compassion is something that's super important that all of us can do. And we can do it by noticing first how we talk to ourselves. If you're talking to yourself negatively, calling yourself names, telling yourself you're stupid and you can't do anything right, that impacts you, that hurts you. It's just like somebody else saying that to you. Try to talk to yourself the way you would talk to a loved one or somebody you care about or a child or a friend. That's the way we want to talk to ourselves. So if we notice that voice in our head being negative, being hateful towards ourselves, we can stop it, maybe take a deep breath, focus on that negative voice, that negative thinking, that spiral of negative thinking, and change your thinking. You can change your own thinking. By the way, it took me a long time to catch on to that. I didn't realize that for many decades. And now that I do it, I smile to myself every time I do it. By the way, I do it when I'm driving. If somebody cuts me off in traffic, instead of yelling and getting upset, I think about what my inner voice is saying. I usually smile to myself, maybe take a breath, and I move on. And it's really changed the way I feel, the way I feel about myself. I'm less anxious, and I'm a better person for being self-compassionate. So focus on that.
Yeah,
What a great thing to talk about.
I tend to be very critical of myself, so I think that has immediate application in my life.